in the last few years. We keep on isolating bacteria in the ICU. Many times they are not responsible for infections. So I'll ask Dr. Suresh Ramasubban, who is in charge of the critical care unit at Apollo Hospital in Kolkata, that when you isolate infection, a bacteria, you get a report, and the patient is all right sometimes. So what I'm trying to ask you is that how to differentiate between a colonization and infections in the ICU.
Correct. I think this has truly become a $1 million question because it will save us a lot of money, and we use a lot of antibiotics in the ICU, as you rightly said. I think antibiotic use is probably the #1 cost in the intensive care unit now. I think going back to Koch's postulates is probably the right thing to do. In the sense, Koch's postulate says that an organism is responsible for the disease if it is grown in pure culture from a diseased patient, and that is the key, whether the patient is diseased or not. And that is a clinical medicine, and that's where the art of medicine comes in, I think. And as you rightly put it in the question itself, that if the patient is getting better, if the clinical parameters are improving, then any bacteria grown in culture is not taken from a diseased patient but from some other human being or some other organism, and it will grow something. So I think eventually the distinction between colonization and infection is the core of intensive care medicine. It's the contextual clinical medicine, and that's where we clinicians should need to be vigilant and be taking care of it. So you have to get into the art of medicine and say, is there infection, is there signs of infection, temporarily is the patient getting better or not? I think that's the key in this.
I think basically what you're trying to say is that if patient is all right, and you have to treat a patient, not the report.
Absolutely.
So basically colonization, it is a clinician decision whether he should take that report or disregard it. And that brings to me very important questions. How to select antibiotics when you think a person has infection?
Yeah, when a person has infection, I think selection of antibiotics becomes absolutely not only important, necessary, but even the speed of giving antibiotics, as we've seen various studies showing that speed of giving antibiotics is important. Giving an antibiotic, there's no doubt, it is actually there's no real reason to even give science to say that if you have to give antibiotic. It's very obvious. It's almost logical to us that if you have bacteria, antibiotics makes sense. But there are studies which have been shown that if you don't give antibiotics or if you give inappropriate antibiotics, your outcomes are going to be different. So how to select an appropriate antibiotics? And I think to select an appropriate antibiotic, we really first need to say where are we dealing with the infection in. I think what is important is to identify the site of infection, and I think that's where the key is. And then also to find out whether, I think contextually, the antibiotic selection will also be whether it's a community or a healthcare associated infection. I think that is the starting point of identifying where the infection is. So you have to have a good proper history and physical examination, because even if you look at any guidelines, this gives us 1 hour, doesn't it, to give the appropriate antibiotic, 45 minutes to 1 hour. That's more than adequate time to get an appropriate history and physical examination. Do a laboratory diagnosis which are rapid. So doing a spot urine dipstick to say whether there's a leukocyte estrase or nitrites is an example of whether you can immediately diagnose a UTI. A microscopy of a sputum or a microscopy of a CSF are things which we should be able to use much more to diagnose infection and therefore to treat antibiotic. So if you have to ask me how to select an antibiotic, the answer is that you need to diagnose infections and diagnose the infections correctly, and that's how you select it. That's a broad first principle of selecting.
That brings me to a point. So what are the factors which will determine that you will select an antibiotic A or B?
The factors is first is whether it's community, site, and whether it's, so #1 is site, where the infection is. Because I think one of the conundrums of having definition of sepsis and all these things is a very good definition for you and me to understand how sick the patient is, to have management protocols. But to give antibiotic is not the right thing, because for antibiotic you need to say whether it's a pneumonia, whether it's a urinary tract infection, whether it's an appendicitis, cholecystitis, rather than to lump them into one thing and say sepsis. If you don't, because the organisms causing infection in different sites are different. So we need antibiotics. What does it mean? It means antibiosis. It means against life. So we are trying to kill somebody. If you're trying to kill somebody, we need to know who we are killing. So that is the key. We need to find out who is it that we are targeting.
So most likely organism,
most likely
infection site.
Infection site, most likely organism, whether it's community or healthcare associated, and whether because if it's healthcare associated you are carrying a risk of resistance, and also in community acquired is there a chance of resistance because of the pressures in colonization that we have in this group of patients.
You know, the other thing which you said about the identification of site, you also said about the kind of organism. I think is even more important when you describe or prescribe an antibiotic, that whether it penetrates to the site of infection, because just sensitivity is not enough.
Absolutely.
And what are the any other thing which you think?
I think there are 4 things that we need to really talk about when we talk about appropriate antibiotics. You know, identify the site of infection. That's number 1 for sure. You know, bacteriological statistics, which is to know what bacteria causes what infection in what site. That is the second thing. And then third is to have an appropriate knowledge of the antibiotics that we use. We need to know the antibiotics, what is their pharmacokinetics and their pharmacodynamics. And the last 4th thing is the fact that we need to use it in an optimal fashion. That means to get the maximum efficacy out of a thing which is going to not be sustainable in the region. So these are the 4 things.
That means proper dose and proper route.
Proper dose and proper route is absolutely mandatory, in addition to the fact. So basically it comes down to good clinical medicine, good microbiology knowledge, good pharmacology knowledge, and that's what is second MBBS and third MBBS.
What is bacteriological statistics?
Bacteriologic statistics is nothing but to say what organism causes what organism causes a particular disease in a particular organisms. For instance, if we say community acquired pneumonia, we are chest physicians, you know, what do we say? When we say community acquired pneumonia, we say that what is the order of prevalence? 85% of community acquired pneumonia all across the world is caused by Streptococcus pneumonia. Yeah. So that is your bacteriological statistics, that if you have to cover one bacteria in a treatment of pneumonia, you should cover Streptococcus pneumonia. Correct. So the 2 other organisms are Moraxilla and Haemophilus influenza. You might get data from All India Institute, you might get data from...
There are some reports of gram-negative also causing...
But the predominant, the statistics says that more than 80% will be these 3 typical organisms and 2 atypical organisms of Legionella and Mycoplasma. So these 5 organisms in a young, healthy, community-acquired pneumonia should take care of everything. So your broadest spectrum antibiotics need to cover only typical and atypical. It does not mean using meropenem and or carbapenem or any other thing. It only means a broad spectrum antibiotic in a pneumonia means covering all the typical as well as the atypical organisms. That is what broad spectrum truly means, and that's where bacteriological statistics is, that we need to remember and memorize it and know what causes infection. So if you say UTI, it has to be Enterobacteriaceae. Then you say, okay, in India, Enterobacteriaceae, E. coli, Klebsiella are all resistant, are ESBL. Yes. Then I can understand that you want to use a level 2 carbapenem or so on. But
so one needs to know in the order of
importance. So bacteriological statistics is bacteria causing infection in a particular organism and the order of importance. And this is extremely important for nosocomial infections, where you know in your hospital might be different from my hospital. You might be Klebsiella, I might be Acinetobacter.
Yeah, because then you need to know the local epidemiology. You know, then the other thing is, we are in the era when there's a lot of MDR organism all over. So when to suspect that the person is infected with an MDR organism?
I think the colonization pressure in our country is so much. I think data is very clear, the Moser study, the SMART study. It's very clearly showing that almost community infections, especially UTI, E. coli, almost 70% are ESBLs. In the hospital or in an infection of this thing, what we say, the classical teaching has been that if you have received antibiotics in the last 90 days, if you've been to a hospital or a healthcare facility in the last 90 days, you had any surgery in the last 6 months, you know, all these things. But I think we are living in an era of colonization pressure, wherein if you have been to any hospital for more than 48 hours, you're going to get an infection with a multi-drug resistant organism or a drug resistant organisms, rather than the early and late definition of ventilator associated pneumonia, which is what the Western textbooks will say.
I think even the early ventilator associated pneumonia could be a drug resistant, depending on
colonization pressure. The colonization pressure in your institution. So there are public institutions which may not be that having colonization pressure, but private hospitals where they're dealing with a lot of high-end antibiotics may have a larger antibiotic pressure.
So I'll ask you the question, what is optimal antibiotic therapy? That's another very important
The optimal antibiotics means the antibiotic which gives you the maximum efficacy. That is the word. The word is maximal efficacy. So how do you want to give a maximal efficacious drug? So you want to give the drug in such a dose. So giving, say, ceftazidime at 500 milligram, when you started, ceftazidime was launched by Glaxo or whatever company in 1990s, you would use 500 milligram to 1 gram. But now the accepted dose is 2 gram 3 times a day. So the right dose is very important to get this bacteria. And the classical example is to understand the pharmacokinetics and pharmacodynamics, that there are certain antibiotics which are concentration dependent and certain antibiotics which are time dependent, and certain are both. So for that is why we have changed, isn't it?
Can you enumerate the antibiotics which are concentration and
so the classical example of a concentration dependent antibiotic is aminoglycoside. So you give aminoglycoside as, say, amikacin, you give 15 milligram per kilogram in one dose rather than 7.5 milligram in 2 doses. And the one which we use nowadays most is colistin, which we tend to use a very high dose because we want that depends both on area under the curve as above the MIC. So you want both a high concentration
and for a longer time, for a best efficacy.
For the best efficacy. So we need to understand.
Colistin falls in that group.
Correct. So we need to understand this concept of how the drugs are, how both the pharmacokinetic, pharmacodynamic variables. And the pharmacodynamic, the other thing that happens in critically ill patient is that your volume of distribution is very high. You are septic, you're giving large amount of fluids, your free albumin is going down, so the amount of free drug may be high, the kidney clearance is not there. So all these factors also need to be. So efficacy also means that you don't cause any side effect.
It is extremely important to know the pharmacokinetics and dynamics. Like, for example, the TG cycline doesn't stay in the blood. Yes. So if you use in a bacteremia, it will never be useful.
It's a black box.
So I think it is important when you prescribe antibiotic, you need to know about the drug to use it appropriately. And so I think the other very important thing is to give an appropriate dose. Very, very important. And lately there are papers which are saying that probably higher dose is more optimal. But whatever is recommended by the international and the national guidelines, you should follow that. So once you started, most of the time you start with broad spectrum. So how do you de-escalate antibiotics?
I think one of the problems with this hit hard and this theory is that you have to de-escalate. Correct. You don't want to rock a boat which is sailing steadily. But we have to de-escalate. There are now at least 2 or 3 studies which have clearly shown that even if when you get an appropriate culture and if you don't de-escalate at that time, your mortality is going to be higher. Highest mortality is going to be when you escalate therapy. Next highest is when you're not going to de-escalate, and the best outcomes are going to be when you de-escalate. So there is no doubt, and this is true in severe sepsis, this is true in pneumonias, this has been true in a lot of infections. So we need to de-escalate. Our problem comes because a lot of times our yield of microbiological cultures is not very high, especially in peripheral units and peripheral units where there's not microbiological support that we get in, say, a tertiary care hospital or a public sector hospital that in bigger cities. In a smaller city, that's where the problem of de-escalation comes.
Because there are studies also, they have shown, like particularly in MRSA, if you find a sensitive Staph aureus, the mortality would be higher if you continue with the drug. Absolutely. And rather than coming back to the cloxacillin.
Absolutely.
So de-escalation is so that brings me a point. A lot of people rely on procalcitonin on de-escalation. Do you think there is a role of procalcitonin in or any other biomarker in de-escalating?
The prorata study, I think the study that has shown that there is some improvement was in 2009, but the recent 2013 study did not show that significant benefit of de-escalation of using procalcitonin. But I think in an era where we have microbiological support is limited and where we have a significant input from serological tests like procalcitonin, which are rapid available, which can be done on site, I think that's probably I think it's a very valid idea to use it. But the point is you need to have a baseline value. So the initial baseline, if you don't have a baseline value and then you have a 72-hour value, that's of no use.
So just, suppose I get a negative report, 0.1 or something like that. So then probably, that probably it may not be there, but many a times I think there is no replacement for your clinical judgment. The clinical judgment along with the test is only important. Another thing, Suresh, is that many a times people just continue drugs because patient is on a ventilator, patient is in an ICU. So I think it's important that we should give for appropriate duration. So what do you have to say, how long to treat the people with the antibiotics?
Short is sweet.
Short and sweet.
Short and sweet. So I think there's no doubt about that we need to keep it short. I think the initial Shastra study of 8 days versus 14 days for ventilator-associated pneumonia holds true, and this is true for urinary tract infection. You don't need to treat for more than 5 days. The data is very clear. So only few diseases need long-term
But you know, there are bacteria like non-fermenters.
That's
like,
where we don't have data.
But whatever data is that at least you treat them for 14 days, Acinetobacter and Pseudomonas.
But as I said, if 10 days you're better, there is no harm in in stopping. There's no data which says you have to do 14 days. So because if you...
But longer duration is recommended for those as of today.
As of today. But longer duration, I still say it will be 10 days, not 14 days or 21 days. And just because the patient continues to stay in the ICU, he need not get the antibiotic.
All right, you started antibiotics and it is 5-6 days down the line and your patient is still sick, still suffering, still hemodynamically unstable. So what's your approach with such a patient?
That's the if you're in critical care infections, this is the challenge. This is the challenge where the automatic assumption is that the bacteria that I'm treating is getting resistant and we have to escalate and change.
You know, many times you find that you isolated Acinetobacter. It is sensitive, you know, in your ICU. You start antibiotic, your patient is still not better. And his fever is still continuing, he's still hemodynamically unstable. So what I'm trying to ask is, what is your approach in such a case?
First is, have we given adequate doses for adequate duration? So this is again another important
systems.
Correct. Important statistics, like what is the median time to resolution for say a community acquired pneumonia? 3 days. So before 3 days, if patient still has fever, is not getting better, be patient. So median time of resolution of a ventilator associated pneumonia is 5 days. Some people may take 7 days, some people might take 3 days.
So wait, first is
be sure that you have
at least 72 hours.
Correct. You have treated with adequate doses, that means correct doses for adequate duration of time before you say no, something else is wrong. If you have treated adequately and they are not getting better, the number one thing is source control. Are we missing a small empyema in a pneumonia with this thing, or are we creating a lung abscess? So I think imaging. So I'm talking just from an example from a ventilator-associated pneumonia. But say if you're treating a non-specific infection, then is there a collection somewhere? Is there a pus somewhere that needs to be drained? Especially in post-surgical patients, they might have a collection in the abdomen, they might have a collection in the wound. So I think, is there a focus of infection which needs to be drained or which is not amenable to antibiotic is a second step that we need to take. And I think then only I would say go to the third step and say, oh no, it is getting a MIC creep and it's not responding and all that thing. I think those things are the issues which needs to come later. The first issue is, have you treated adequately? That's why, have you given optimal antibiotics for an optimal duration of time? Have you looked for source control? And if you have done these two, then you might say, okay, this probably may be an antibiotic failure in this instance and I might need to change my antibiotic for that same bacteria as what you're saying. But that should be the last option and that's not the first option.
And the other thing is, look for something else you're missing. Absolutely. Like a collection, like suppose there could be a pleural effusion, there could be an empyema. So alternate. I think if your patient is not responding, then you should examine and look for an alternate. Am I missing something?
Absolutely. We had a patient, just an anecdote, I don't know, anecdotes are not really great, but we had a patient who has got persistent MDR Pseudomonas urine culture and on dialysis, we're giving high dose of colistin and not getting better, fever persisting and diarrhea persisting, GI intolerance persisting. And we are again debating how much to dose in renal failure, have we given optimal? But we did a simple stool for C. diff toxin and C. diff toxin comes back positive. We stop the antibiotics for this thing and give him, and treat this as a colonization because of a chronic Foley catheter and treat him for C. diff and he gets better. So that is an example of a situation where this might be a red herring, as they say, and not a true pathogen. So that, I think, going back to the first question.
So basically, if the patient is not getting better, you need to go back to the patient, see that whether you have given adequate duration. If 3-4 days are over and the patient is not responding, then you need to re-examine the patient. Are you missing something? Alternate source of infection or fever? Is it a non-infectious which you are thinking of fever? Or there is some other collection in the body, and then appropriately do the test to diagnose the infection?
I would say that a new fever for a student is basically a new short case.
Yes, that's correct.
I think the approach should be that you're called to see a
examine from head to
go back.
Head to toe.
It's a short case. It's not a long case because the long case is obviously his COPD and whatever he has on a ventilator. But the short case is, today's short case is that he has had fever, How do you approach it? Or a leukocytosis, and you go like a short case and you solve the problem rather than to say what antibiotic to change.
So the infections in the critical care unit is a common entity, and they would be there. And we have limited antibiotics, and we need to use them appropriately, and for that you need knowledge. You have to identify what is the likely infection site. Then you have to, which is the biological statistics, that means which is the most common organism you think you need to cover. Then your antibiotic in the beginning could be a broad spectrum, that based on the culture sensitivity you need to de-escalate, and it has been shown the de-escalation will improve survival rather than continuing the combination of drugs. Then you need to give that for a proper duration, need not continue beyond a certain time, whatever has been recommended by the guidelines. And when you are sure that it is non-infectious, you must stop antibiotics. We have limited antibiotics, so we need to use them appropriately and adequately to get the good result in patients.